All right, we're gonna get started now. I just want to point out that I took this quote directly from Brian Flores' Instagram, so enjoy it. This is a EM CCM conference. D'Souza may come in, he really wants to see this also. So if you don't know me by now, I'm Chris Hanuscin, I'm one of the PGY3s, almost 4s, I know. So I want to give a special thanks to Dr. Eden Kim and also Dr. D'Souza for helping me with this presentation. So we're going to go ahead and get started. So this case, it was actually a notification. The EMS phone rang in CCT. They just got a call saying this is a stroke pre-note, no other information. Very common. So stroke code was activated prior to the patient actually coming in. So EMS arrives, they say that they responded to a seizure call actually, but when they got there, the person was alert, talking to them and saying, I just fell. And then while they're talking to her, they are trying to get her vitals, and then all of a sudden she goes into cardiac arrest right in front of them. Luckily they already had her on the monitor because they were getting vitals, and they saw that she was in polymorphic VTAC on their monitor. So they did, in their note, cardioverted her twice. They got ROSC. They said she came back to baseline in between each time. And every time she got ROSC, they tried to get IV access en route, but could not. They said when she did come about in the field, these were her vital signs, fairly unremarkable. They put her on a non-rebreather right away. She was satting 100%. She was alert. She was awake, alert. However, she did have some slurred speech and wasn't fully following commands for them in the field. They did a 12-lead EKG, and they saw no elevations or depressions. So patient is there in front of you. So like good EM physicians, the team went through the ABCs. So airway was intact, breathing. Patient was a little tachypnic on the non-rebreather, but clear breath sounds bilaterally. No bleeding anywhere, a little tachycardic. And then disability, she was alert, but when she was talking, she had a little bit of slurred speech, and then she had right-sided weakness. These were her initial vital signs. Again, a little tachycardic, a little tachypnic, but afebrile, satting well, glucose normal, 136. Blood pressure, a little high, but fairly normal, 165 over 114. So some of the juniors, just based on the initial assessment, what are some problems just based off that? Weakness, yeah, focal deficits. Anything else?
Cardiac arrest.
Yep, cardiac arrest. Yeah, the tachycardia, the tachypnea, and the focal deficits. So based on this, as EM physicians, IV O2 monitor, they already had a non-rebreather for oxygen, even though she was satting well, and she was going into some type of arrhythmia in the field, so you want to get an EKG. We'll go over those later. So this is a little of the initial history. So we have a 50-year-old female. She has a history of a hemorrhagic CVA, so she has chronic right-sided weakness. This is what she's giving, by the way. There's a questionable prior history of an MI. She had a DVT on rivaroxaban, that's Xarelto. And she presents after a fall with lots of consciousness at home. So like we already went over, EMS found the patient unresponsive and poly-VTAC. They performed CPR. They defibrillated twice with return to baseline. And then patient had 2 more episodes of VTAC. And she was socked twice. A little more history. Sorry. So on external medrec, which we were able to find later on, is that patient was on aspirin, Lipitor, she was on carvedilol, she had seizure history, she was on Keppra, lisinopril, and Seroquel 25 milligrams, and she had no known drug allergies. Social history, she didn't drink, she didn't smoke, no illicit drugs. I had a question, she was 50 years old. Family history, non-contributory at the time. So physical exam, generalized, patient was no acute distress, sitting there talking to you, ANO ×3. Had a neck exam. She did have a small abrasion over the supraorbital area on the right side, where extra oculomotor is intact, perla, neck was supple. Cardiac pulmonary exam, little tachypnic, the lungs were cleared auscultation bilaterally, little tachycardic, regular rhythm, normal S1, S2. Abdomen soft, non-tender, non-distended. Neuro exam, again, little distorted speech. She had a right lower facial droop. She had right lower extremity drift. It didn't hit the bed, but they were unable to access right upper extremity because she wasn't really following commands. So again, anyone in the audience or at home want to throw out some differential diagnosis of what could be going on? Yeah, CVA, ischemic or hemorrhagic. Mm-hmm. Right. Mm-hmm. Seizure was said. Arrhythmias, like what type? Mm-hmm. 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 Different ventricular dysrhythmias. Right. Yep. So a malignant ventricular dysrhythmia, different causes. Mild cardiosquemia is just an ACS, is electrolyte abnormality, hypo-K, hypo-MAG, just drug induced. We saw her meds, just idiopathic. Somehow it happened. Again, we mentioned CVA, intracranial bleed, a carotid dissection is something to think about. She's having neuro symptoms. PE, she has a history of DVT. I don't know how compliant she is on the Xarelto. And then she has a history of seizures. It was a seizure. EMS call could also be a seizure. So actually, while the team was examining her, she had several episodes of VTAC right in front of them. In their note, they said cardiovert, but I don't know what they did, defib or cardiovert. And patient would immediately, as soon as they had cardiovert, awake, start talking. They astutely gave 2 grams of MAG right after they got her back. They gave her 2 grams of calcium. And then luckily in between all this, they were able to get a EKG. Do one of the juniors want to read it just briefly? I'm just going to repeat for people at home. Natasha is saying it looks like normal sinus rhythm. She has P waves for every QRS. Borderline sinus tach, maybe around 90. Two T-wave inversions and 2 in AVF. And 3 in AVF. I didn't really notice any ST depressions. And we'll talk about the QTC a little bit later, but I just want to know that there is studies out there that shows manually versus computer assisted versus automated. They're all comparable. Automated was actually a little more precise, but they're all comparable. So you can trust the computer, but you can also measure it yourself. We'll talk about the QTC again later on. Oh, sorry. What some testing do you want to get at this point? What do you want to do? Mm-hmm. Mm-hmm. Yeah, so what the team did, they got labs, CBC, CMP, troponin, MAG, D-dimer, a BNP. They got digoxin for unknown reason, and the person wasn't on digoxin. VBG, coags, TFTs, patient's a little tachycardic. A head CT, we were worried about a CVA. This is still a stroke code. Neurology is already on board, but because patient went in cardiac arrest, had multiple dysrhythmias in front of you, you can get a cardiology consult also. So while they're drawing the labs, again, the person is going into polymorphic VTAC a couple times. According to the team, it's about every 20 to 40 minutes at this point. So a second round of MAG was given, 2 grams IV. The patient couldn't go to the CAT scanner, too hemodynamically unstable. Still going into polymorphic VTAC even after the MAG and the calcium, so they started on esmolol drip, sorry, at 30 mics per kg per minute. Just of note, the usual dose is 500 mics per kilogram bolus, and then you get 50 to 200 mics per kg per minute. This is what the team decided to give. We'll go over the treatment. Yeah. We'll go over that, but yeah. But unfortunately, patients still go into recurrent VTAC requiring defibrillation, so they give amiodarone, an antiarrhythmic. They give a 300 milligram IV bolus. After the amiodarone, time spaces out more to about 45 minutes per episode in between, but you had about 1 or 2 more after that. So they gave a second dose of 300 milligrams of amiodarone and then started a drip at 1 mg per minute. And then, unfortunately, the patient had 1 more episode. And so at that time, a TVP was decided to be placed. After they placed the TVP, they got this EKG. Do one of the seniors want to try and read this? Say what they're seeing? Maybe Charles.
It should become very bradycardic.
Not that was noted in the chart. They were thinking of overdrive pacing at this time, or speeding the heart up. What do you think of the rate? It's fast. It's still below 100. It's like border.
It's like 150. It's like, yeah.
And then do you think it's capturing? Look in the middle of the EKG.
Yeah, that's the rhythm script on the bottom. It's like
some are, yeah. Yeah, some are capturing, some aren't. So if you were to see this on the EKG, you might want to turn up the current a little bit so they all capture. And then after they placed the TVP, they got a chest X-ray, fairly normal, just shows some evidence of pulmonary vascular congestion and a large cardiac silhouette. And then they did see that the right-sided TVP was now in place and was right over the right atrium. So after they placed the TVP, the patient still went in to polymorphic VTAC, although less frequent at this point. I think it happened about an hour after they placed the TVP. So at this point, they decided to go ahead and intubate the patient. They intubated with etomidate and rocuronium, and then they placed her on a propofol and fentanyl drip. These drips were decided to cause sedation to try and reduce that sympathetic drive, because sometimes anxiety and a lot what's going on can lead to more events. So they want to reduce all that sympathetic drive and hope to reduce these events. So results start to come back at this time. The patient's able to go to CAT scan in between this after being intubated. So the VBG you guys ordered came back. Little acidotic 7.25, CO2 is a little elevated at 67, and then a lactate of 4.1. So this shows a little bit of a respiratory acidosis, maybe in a metabolic lactic acidosis at this point. Your CBC come back fairly unremarkable. However, D-dimer is elevated to 4,000. A little bit of troponin leak, 0.014 BNP. So with the elevated D-dimer plus signs of right heart strain like the troponin and BNP, they decided to get a CTA in addition to their CAT scan earlier. So patient went to CAT scan. Just of note, so this is actually, there is a large area of encephalomalacia over the left side, but that was all from her old stroke. None of that is new. That was all chronic changes. She did have a little dilatation of her ventricles and bilateral ICAA calcifications and just mild chronic microvascular changes. But no acute bleed, no acute intracranial process. They also got the CTA, so there was no PE, a little bit of cardiomegaly, and then just incidentally found she had a right breast mass that measured 3.8, 3.7.
In abdomen.
Yeah. So cardiology writes their notes. So a little more further history that was not in the ED notes. That was just one liner in the cardiology note. Patient actually had a colonoscopy earlier that day, and then had only been home for a couple hours when this happened. So their assessment was this is polymorphic VTAC resistance to treatment. Continue with the esmolol and amio. Continue with sedation, fentanyl and propofol. If another event happens, shock, bolus with amio. Follow up MAG and FOS levels. They weren't back at that time. Trend the troponins until it was elevated. Get another EKG, and then admit to CCU. And then while in the CCU, get an official echo and EP study. Remember, this was a stroke code. Neurology is already on board, so they wrote a note just saying to repeat the head CT in 24 hours. They'll get an EEG to see if there's or seizures happening, even though we know that we saw dysrhythmias on the monitor. And then they're going to defer the antiplatelet and anticoagulation for the primary team. So does anyone know like what the leading diagnosis is at this point? It's actually refractory polymorphic VTAC that they kept seeing. They tried all these treatments. They kept happening. We'll go over what an electrical storm is later on. However, when we looked at the ACR reports, we actually saw the rhythm strips at EMS got because it was never captured here in the ED, and you see this rhythm that was seen by EMS. So it does look like a polymorphic VTAC. It looks like a specific type of polymorphic VTAC that we'll talk about. So there's this one. There's this one isn't loading. It might not come up. It was just another rhythm strip. So going back to the first initial EKG that they had got. So if you look at the QTC, it's actually a little prolonged, not severely prolonged, but it is prolonged at 494. This was, which was read by the computer. And then if you look on it, you can use MD Calc actually. I'm going to go over how to calculate QTC. And if you use the Bazette algorithm on MD Calc, they still got 494 at that point. So this is polymorphic VTAC. However, it's polymorphic VTAC with an elevate, with a prolonged QTC, and there's a specific condition that is. And so in conclusion, this is actually Torsades. So that's what this whole discussion is going to be about. So we'll go over difference between what VT storm is and Torsades, torsade de points, twisting of the points, some causes of Torsades, and how to manage it. So they were managing recurrent polymorphic VTAC, which is a little different than Torsades, and we'll go over those differences. So what is VT storm? So VT storm, or actually called electrical storm, is 3 or more episodes of sustained VTAC. And VTAC, as we know, it is a regular wide QRS complex tachycardia. Some of the causes of the VTAC are ACS, myocardial ischemia. You get hypo-K, hypomag. Torsades is one of them. Could be drug-induced or idiopathic. There are different algorithms to determine is this SVT versus VTAC, which is very tough to tell sometimes. SVT with the variancy. You can use the Verikai algorithm or the Brugada algorithm. There was a study done by the European Society of Cardiology that showed that the first step of the Verikai criteria, which is actually looking for an initial R wave in AVR, is the more simple, accurate, and reproducible step in determining this. But if that one is not met, then you have to use a little combination of Brugada and Verikai algorithm. But of course, use this only after you treat the dysrhythmia. So treat the dysrhythmia, patient's unstable, then go back and diagnose exactly what it was. So there are 2 types of VTAC. There's monomorphic and there's polymorphic. Monomorphic really means that the waves all look the same. So that's the top EKG here. As the EK is showing that it's symmetrical all the way across. It looks sinusoidal, and then your polymorphic, each of the twisting have different amplitudes and they look different, making it polymorphic. The treatments are a little different. The monomorphic you could treat more as like a VT storm with cardioversion, beta blockade like esmolol, amiodarone, and then the polymorphics are different in terms of that's more your Torsades. And we'll get into the treatment a little bit later. That's going to be your magnesium and your pacing. So what is Torsades? Torsades is only one type of polymorphic VTAC. Its characteristics, it's actually polymorphic VTAC with an QTC prolongation. And then you get that R on T phenomenon. You get depolarization during repolarization of the beat before. And you get the gradual change in QRS complex, making it polymorphic. And we'll look at a rhythm strip showing what that is. And then the name twisting of the points, that's just, it looks like the points are twisting around the isoelectric line. Other characteristics described in the literature show that torsades is in association with antiarrhythmics in the vast majority. Usually a positive response to unusual treatments such as isoproterenol and cardiac pacing, and you get lack of response or even aggregation by standard antiarrhythmic therapies, which could be what happened in their case. They were given amiodarone, they were given esmolol, and it was only aggravating the arrhythmia. So there are a couple different mechanisms of dysrhythmia. We're really only going to talk about one of them, but I just wanted to briefly touch on all of them. So there's reentry, abnormal, enhanced automaticity, and then a triggered activity like RNT, which is what we're going to be talking about. So your reentry dysrhythmias are your accessory pathways like your AVNRT leading to SVTs, also your idiopathic VTAC. Your abnormal automaticity is like your ectopic atrial tachycardia. There's a pacer cell in the myocardium that becomes excited and starts to speed up and now control the heart. And then your enhanced automaticity is your sinus tachycardia. And then your triggered activity is like your RMT phenomenon. I can't even say that word sometimes, phenomenon, which is your torsades. So this is that changing of the amplitudes in the QRS complex that I was talking about, your twisting of the points around the isoelectric line, and that's all caused by RNT phenomenon. So I'm going to take you back to med school. We're going to look at the cardiac action potential, how it correlates with the QRS complex, which will help you understand what leads to torsades and what leads to QT prolongation. So just try to get the mouse over here. So this upstroke here is actually phase 0. This is it's led by your sodium channels. Sodium is leaking into the cell, causing depolarization, actually leading to your QRS complex. At the tip over here is your phase 1. The sodium channels start to slow down. Your potassium channels start to open up, leading to potassium leaking out of the cell. And then your phase 2 here, the calcium channels and your slow potassium channels start to equalize out, causing a plateau, and that gives you your time in between the QRS complex and your T wave. But the most important phase that I want to talk about here, which we'll get into, is your fast potassium channels, which actually account for the majority of your QTC interval. And so depending on how fast and how slow these channels open and close is how long your QTC will be prolonged. So there's 2 types of channels like I was talking about. There's your slow potassium channels, there's your fast potassium channels. So most drugs that lead to QTC prolongation will affect your rapid potassium channels. They'll block these rapid potassium channels, therefore causing this slope to be a little more prolonged, leading more to your T wave being further down the line, leading to QTC prolongation. When this happens, actually, you can get early after depolarizations, meaning another P wave earlier in the cycle, and that can happen on your T wave, and that's what leads to your torsades. So how do you calculate your QTC manually? There's one formula that's shown to be one of the best formulas, is BAZET formula. So it's actually the time interval of your QT interval over the square root of R to R. So like here, remember your little boxes are 0.04 seconds, your big boxes are 0.2 seconds. So you just put those 2 numbers over each other. If you don't know where your T interval ends, because sometimes you have a U wave, they look like they're put together, or you just are unsure exactly where it ends, look for where your slope is the greatest. So as you can see here, your T wave, and then your slope is the greatest. So then right here on the isoelectric line is where you would actually stop your QT interval. But if there's a U wave after your T wave and it's connected, you look for the slope that's the greatest, which is after the U wave here, and you're going to measure right here. Just to point out, the QTC intervals averages are different for males and females. So normal for males should be below 430. Normal for females should be below 450, and above 450 for males and above 470 for females is prolonged. That's like the top 1%. So our patient was 494, so she would be in the top 1%, and hers would be considered prolonged. So a couple of causes of torsades, which we'll go into a couple. There is drug-induced torsades, usually your QT prolongation drugs. But also if they're on QT prolongation drugs and then other drugs are added, such as CYP3A4 inhibitors, that can actually worsen the QT prolongation, because most QT prolonging drugs are broken down by that CYP3A4 inhibitor. Electrolyte abnormalities such as hypo-K, hypomag. You have your bradycardia and pause-dependent torsades, and then we're not really going to touch on this one, but you have your congenital long QT syndromes such as Romano-Ward or your Jervell and Lang-Nielsen, which is the long QT syndrome plus deafness. So here goes a long list of all the drugs that can cause QT prolongation. It's very long. You don't have to memorize it. I'm just going to read a couple of the drugs that we use on a daily basis, that we hear about on a daily basis, just from this list. There's even more not on this list. So procainamide is a very common drug, amiodarone, macrolides. I know that's important in this time, especially with the azithromycin. Your fluoroquinolones, chloroquine, which we're hearing a lot about in the news today, Haldol, methadone, which we do see quite frequently, and quinidine. And then some of your CYP3A4 inhibitors that can, if they were added on with these QTC drugs, can only worsen the QT prolongation, are drugs like nicardipine, Versed, fluoxetine, a lot of the HIV meds, macrolides, isoniazid, OCPs, even tamoxifen. Usually the QT prolongation or torsades usually doesn't happen right when you start the drug in the early initiation. It usually only happens after you're increasing the dose of that drug, or if they develop some type of electrolyte abnormality, or even bradycardia if a beta blocker is added on with it. Some common drugs that cause electrolyte abnormalities are diuretics. They can lead to hypo-K, which can lead to torsades. There are a couple of websites to look up these drugs. It's very fast and it's very easy to remember. It's torsades.org. You can just type in the drug and see if it causes QT prolongation. There's also qtdrugs.org. And then actually Torsades and qtdrugs.org will both lead you to the same website. And then there's SADS.org, which is the Sudden Arrhythmic Death Syndrome.org. So that was some of the drugs that cause it. This is a case actually written by one of our former residents, Guy Carmelli and Dr. D'Souza, which involved a couple of the causes, involved drug-induced, bradycardia-induced, even pause-dependent torsade. So this was about a patient, I think he was about a 50-year-old male on dialysis. He came in, I believe it was to downstate. He had fallen asleep at dialysis center. He had an ASCD at a place. He fallen asleep at dialysis and then awoke to a shock. So they brought him in the ED. He actually was awake talking to them. They got an initial EKG. It showed a sinus rhythm with junctional bigeminy, had an occasional PVC, some left ventricular enlargement, but his QTC was 548. They learned at that point that he was on methadone, which they think could have caused the QTC prolongation. His K was 3.6, his MAG was 2.0. So they got EP consult to come down. They said admit to CCU. We'll get an EP study out in CCU. But while he's still in the ED, he about 3 hours in, he lost consciousness, and then on the monitor it looked like he was in VFib. So they immediately shocked him. They gave him, he came back to consciousness. They thought, okay, this could be VTAC or VFib, so they gave him metoprolol at that point. But there was actually a physician at the bedside when it happened, and he noticed the patient was becoming somnolent, and the monitor showed a sinus bradycardia right before this rhythm had happened. So they thought, bradycardia with this QTC prolongation, this is most likely torsade. So they gave him 1 gram of magnesium. The patient actually had one more episode after that, so they started a lidocaine drip, and then he was admitted to the CCU. While in the CCU, he had no more episodes. They changed his methadone to something else. The QTC then corrected on its own, and he had no more episodes the rest of his stay. So it just shows that there is a bradycardia and pause dependent. There are some studies that show that when people fall asleep, they have pauses in their sleep from 2 to 12 seconds. They also can get bradycardic all the way down to the 30s in their sleep. So those two things plus the methadone probably put them into Torsades. They didn't actually capture the events on EKG during this episode, but this is something similar that happened. So this EKG, there was sinus bradycardia with a first-degree AV block. There was a PVC, and then an event happened on the T wave, and then that led to torsade. This is a very common thing seen in torsades when you get your long and short interval. So the PVC led to a pause here, and then you get your normal rhythm. And then because the QTC was prolonged, you had an early after depolarization, and then the patient went into torsade. So we're going to get a little bit into treatment. So it's really broken down into unstable and stable. So if the patient's unstable, you want to defibrillate. You can't cardiovert because they're in a polymorphic VTAC. You won't be able to synchronize with the QRS complex. So make sure in these unstable VTACs, you defibrillate, you do not cardiovert. And when they are stable, the treatment is MAG or speed up the heart, which we're going to go into. So this is one of the first studies done by Tisvoni. He actually does most of the studies on magnesium in torsades. This was his first. It's been since repeated. But in this study, they took 12 patients, and they recognized that all 12 patients had torsade. It was polymorphic VTAC with a marked QT prolongation. It went over 4 years. They gave all patients magnesium. They gave the first 9 patients, in 9 patients, they only gave a single bolus of 2 grams of magnesium, and they all converted and didn't have any more episodes. The other 3, unfortunately, did have a second episode, so they gave a second bolus about 5 minutes later, and the arrhythmia never returned. Just of note, 8 out of 12 of these patients all had hypokalemia, but all of them had normal normal serum magnesium. 9 out of the 12 patients were started on a continuous MAG drip for 7 to 48 hours after admission, and all their QTCs came down below 0.5 seconds. In all the patients that got MAG boluses, which were all 12, there was no recurrence of the torsades. But right after the boluses, there was no change in the QTC, which we'll go over a little bit later. No side effects were noted. There were 5 other patients that they also studied that had polymorphic VTAC with normal QT intervals that they gave MAG to, and that did not. Those treatments were ineffective. So magnesium.
The thing about magnesium levels, the total magnesium does not correlate any to the ionized magnesium.
Right.
So you should, even if you get a normal magnesium in these patients, you should still get magnesium. Mm-hmm. There's no ionized magnesium level currently available. Downstate is the world's expert in ionized magnesium, and we've done some work with them. And the ionized magnesium, which is the active moiety, is not related to the total magnesium.
Correct.
So you should still treat these patients, no matter what their serum magnesium.
Dr. Sinner was just saying that serum magnesium does not correlate to ionized magnesium, so you should still treat all these patients with magnesium. And there's no way to check an ionized magnesium. So why does magnesium work actually? So it's a very important modulator for the ion channels in cardiac cell function. It's actually a cofactor on your sodium potassium ATPase. It helps to stabilize the membrane potential, and it corrects that repolarization process, but it doesn't actually shorten your QT prolongation. It really helps with decreasing the influx of the calcium, which decreases your amplitudes in those early action depolarizations, and then leading to less of a chance of those early action depolarizations to reach threshold potential and decreasing your chance of getting the RNC. But the mechanism isn't fully understood. This is just one proposed mechanism. So usually the standard approach to torsades that most people are taught is to give 2 to 4 grams of magnesium with defibrillation. Then most of these patients are going to get admitted to the ICU. If you don't get recurrence, great. If there is recurrence, people bolus them again. However, there is a better approach, and I'll talk a little bit about why. So the better approach is to still begin with the standard approach. You still give your 2 to 4 grams of magnesium plus electricity. And then you want to start these patients on a magnesium infusion. The infusion starts, you want to start with 1 gram per hour with a goal of magnesium 3.6 to 4.9. If you start to go above 5, you want to reduce by 50%. And if you go above 7, just stop it immediately. And of course, monitoring these patients for weakness, bradycardia, or even respiratory distress. And then very important to note, you want to replete their potassium. You will actually want them to be a little bit on the higher side, 4.5 to 5, and this will help also shorten your QTC.
You also have to be careful with magnesium infusions dialysis. Magnesium is not dialyzable.
Yeah, so
if you overdo it, you can't get it back.
Yeah.
For a long time.
So make sure you check their GFR. This is safe in a GFR above 30. Their GFR is less than 30. Then you want to just keep loading them with mag boluses. The reason that this works. Correct. Yeah. The reason that this works is because magnesium is similar to naloxone drips, like for methadone overdoses. It takes time for the magnesium to actually get intracellular. So even though your serum mag may be normal, your intracellular mag, your ionized mag might be lower. So these infusions help to replete that intracellular magnesium. Sometimes this takes over 24 hours to get that magnesium into the cells. So keep them on it for 24 hours. Once their QTC becomes corrected, then you can go ahead and stop it. So that's great for people who are hypomagnesemic. But if that's not working, there could be a bradycardia or pause-dependent torsade, and this is when you actually want to speed up the heart. So there's 2 ways to do that. There's chemically or electrically. So chemically, you want to use isoproterenol. You start it at 5 mics per minute, and then you want to titrate to 30 beats per minute above their baseline, or until you get the torsades to go away. It's unfortunately, isoproterenol is contraindicated in people with congenital long QT syndromes, or if they're having any ischemic heart disease. You can only further exacerbate the ischemia. So there is transcutaneous and transvenous. Transvenous is preferred because you get better electrical capture, and then you also don't need to sedate the patient. Transcutaneous is very painful. You're going to have to sedate them, and you can change their mental status, which is hard to watch. You want to turn the heart rate up to about 90 to 100. In patients that are just drug-induced QTC prolongation, you only have to turn it up to about 70. I just want to point out that this is not overdrive pacing. This is totally different. Overdrive pacing can only be done in an EP lab or with a pacemaker. And overdrive pacing is rapid stimulation to try and terminate that VTAC. Lastly, one of the most important parts in preventing torsade, again, is to discontinue all medications that led to the QTC prolongation. So this is overdrive pacing. I just want to touch on it a little bit so you know what it is. The idea behind overdrive pacing is that during these VTAC episodes, there's a time when the myocardium, there's a gap in their excitation. So you want to try and turn up the heart and create a new rhythm that hits during that gap. So the 2 rhythms collide, causing them to cancel each other out, and then kind of restarting the heart again to go back into a sinus rhythm.
You look at electrograms of the device interrogation when the cardiologist comes down. You look closely, you can see that the patient had antitachycardia pacing rather than cardioversion. The reason why the device does this is it saves battery. It uses less energy than so they're all programmed to try overdrive pacing first. If that fails, then move on to cardioversion.
You can't do this with a transvenous. Right. You can't do this with a transvenous pacemaker. Like if you put an acute one in, You can't get it up that fast.
You just can't get it up that fast. In theory, you could if you could get the box to heart rate that fast, but you can't get up that fast.
Probably for good reason.
They're saying that you will not be able to get this fast of a heart rate with a transvenous pacer. This has to be done in an EP lab. So to go a little bit of the inpatient course, on hospital day 1 after the patient was admitted to the CCU, although still boarding in CCT, patient became hypotensive, so the antiarrhythmics and sedation drips were held. It was presumed that the hypotension it's actually expected because the patient was on two beta blockers and a propofol infusion. They were on esmolol, and then amiodarone actually has some beta blocker activity initially. And so this could have led to the hypotension. Unfortunately, the patient went into VTAC.
Yeah.
I think I saw you went into
Shar.
train.
Hi, Shar. Do you mind muting at home?
Sorry.
Patient went into recurrent VTAC, required defibrillation and pacing at that point. The troponin had peaked at 0.1, but then decreased again to 0.098, proving that this was some type of ACS, but it wasn't an occlusion MI. And because the patient was recurrent and unstable, they decided to transfer to MIMO for possible ECMO to get an emergent cath and ablation. So I got a hold of MIMO, got the inpatient course from them. Actually, when the patient arrived, there were no more episodes of polymorphic VTAC. So at some point, the amiodarone and esmolol were all restarted before transport. Those were all discontinued on hospital day 1 at MIMO. Patient was downgraded to cardiac tele on day 2. Unfortunately, sat around for almost 2 weeks waiting to get her AICD placed. There was a scheduling issue. Had no more episodes during that time. And then on day 14, received her AICD and then was discharged the same day. There was a question of cath at MIMO. There was none reported. The person that I talked to said that the patient didn't have any other procedures besides the AICD. And it's unknown if the patient has followed up in clinic yet. They weren't able to see that. So what exactly was responsible for her prolonged QT? My conclusion, there was, patient was on Seroquel. So I looked at Torsades.org to type in Seroquel. Seroquel has been known to lead to prolonged QT, but it usually only causes torsades with the prolonged QT if there is an electrolyte abnormality. So I don't know if you remember, there was a mention in the cardiology note that the patient had went for a colonoscopy the day of the episode and that she used the bowel prep Go Lightly the night before. So if you look at the FDA guidelines that Go Lightly, it actually can lead to seizures secondary to electrolyte abnormalities, specifically hypomagnesium. And then also cardiac arrhythmias in patients with a history of prolonged QT, which she could have had because of the Seroquel, and also recent myocardial infarction. I'm not sure when her MI was. It was a question if she did have an MI, but she had both of those risk factors. So the Seroquel plus the bowel prep leading to electrolyte abnormality could have led to the QTC prolongation, which could have led to the torsade. So in summary, just remember that polymorphic VTAC with QT prolongation is torsade de point. A little bit of the treatment, if they're unstable, you want to defibrillate, then you want to give a MAG bolus and start the infusion right away. If it's recurrent, it could be a pause or bradycardia dependent torsade. You want to speed up the heart, you can do this by pacing. TVP is better than transcutaneous or isoproterenol, and then identify and try to discontinue all your QT prolonging drugs. All right, these are my references. Are there any questions?
That was a terrific presentation. I mean, you really covered it well. I just have a couple of comments and questions. One is that in my experience, if I think someone may have torsades causing the VTAC, I don't go with amiodarone or procainamide. I go with lidocaine, which you did mention on one of your algorithms. I think it's safer. It may not work, but it won't make it worse probably. My other question is about giving the calcium at the same time as magnesium. I know hypocalcemia can cause torsades, but if there's no evidence of that, will the calcium interfere with the effect of MAG? And will it also, if they're not hyperkalemic, in fact, if they may be hypokalemic inside their cells, could the calcium actually hurt them. So that would just be a question of, and then obviously using drugs that slow down the heart, like more beta blockers and things that can also hurt them. So if you consider Torsades, you might want to not use some of the drugs that were used, maybe. But quarterbacking is Monday morning quarterback is not always appropriate.
Yes, thank you. Charles?
Is there any use for any
Charles' question was, are there any use of any of the antiarrhythmics? The one that I found that is in the algorithm that was on EM Crit was lidocaine, like Dr. G was talking about. That one may be the most useful, but the most important is the magnesium and speeding up the heart. Antiarrhythmics actually could lead to aggravation and only worsening of Torsade, especially beta blockers can lead to more of that bradycardia and more prolongation of QT. Yes, Natan?
It seems like there's a lot of practice variations in attending and GPCs. So are there any rules or things that we can use for how long we could sort of QPC? Like, is there a certain number that most patients start potentially the agent for, or a single patient that would come in just for QPC, or a patient that would be brought in or be concerning because of their QPC number? It was just like a screening KG.
So Natan's question was, there's a lot of variation between attendings and practices on what QTC interval that we're most worried about. So how do different attendings practice? What level are they not starting QTC prolonging drugs? When are they admitting for a patient who had syncope?
I think if you have syncope, QTC prolongation,
What is it? 470? We sometimes off of those numbers, but this would be really. I feel like I've heard 500.
I usually use in women is 500, men is 470.
I'll send this to people by Schumacher study on this. We found that basically 500.
Yeah, I was going to say, to answer your first question, if someone's just coming in and I want to start azithromycin on them, if their QTC is less than 500, I usually feel pretty comfortable starting it. Anyone with 500 or over, I really think about, do I need to give that medication? Can I give an alternative? If a patient comes in with syncope, though, then my threshold is different, right? Because now I have the actual complication that we're most worried about with it already. And so I think more when it's in the 480 range, even I just think really carefully, could the syncope be from QT at that point? But 500 is my usual. I just get an EKG, it's like screening EKG. Anything under 500, I'm a little less worried. And 500 enough, I start to think about it.
Also, in the face of hypokalemia, I'm very interested in QTC.
And just anecdotally, my first Torsades patient was severely constipated. We were getting this impacted 20 minutes after I completed it. So there might be a connection between GI stuff and these.
There is.
Was patient on any opioids, methadone or heroin use? It can lead to the constipation also. Just to repeat some of the answers, Dr. Hassel, Dr. Sinner, and Dr. D'Souza all said their cutoff is around 500. Dr. Sinner said he usually would admit if a female had a QTC above 500 or a male above 470. Dr. Hassel agreed with that. They said in terms of starting QTC prolonging drugs, usually below 500 they would be comfortable with that. Dr. D'Souza is going to send out a paper regarding that, and he said that the cutoff in that paper was 500. Yeah, sure.
You're saying it takes a while for drugs to lead to Torsades. So when we're getting worried about giving one dose of Haldol or something, I don't know if you know the answer to that. Is that a real risk?
That's what I had read, was usually the initiation of these drugs don't lead to it, but it's usually when you increase the dose of the drugs, or if you have other factors such as electrolyte abnormality or bradycardia. So I guess it's a low risk.
So like getting an EKG before you
I don't know the actual data behind that.
So here's the trouble, though, right? So you're right, and I don't say, oh, get the EKG before you get the Zofran necessarily, right? Because the one dose doesn't cost Here's the trouble. Let's say the QTC is 520. That means that they're already on something maybe, or there's some issue. If they do go into a rhythm, right, anyone can go back and say, oh, you gave that Zofran and they let it, right? It doesn't mean that it caused it, but it does just mean that they have a higher propensity to it and it just looks bad, basically. Just one clinical point to bring up. We're talking about the importance of increasing the potassium as well, and maybe putting the patient more hypercalemic, right? So if you get a patient like this, how are you going to get their potassium up high enough to get to that point? Right? So how are you going to get the potassium?
So the question is, if patients are hypokalemic, how are you going to give the potassium to get them high enough?
It's just like a practical question, right? So do you guys know about, right, when you give IV riders, you know how they're given, how much you give over how much time?
So usually we have premix 10 milliequivalent riders and 20 milliequivalent riders.
Yes.
Most patients can't tolerate the 20 milliequivalent rider because it burns too much.
Let's say they can. You know how long that it's given over?
Acute has to be given over an hour.
It's 10 per hour.
10 per hour.
So it's over 2 hours. So 20 milliequivalent over 2 hours. It's a tiny amount over a very long, relatively long period of time. So if you have a patient that is awake and can take oral supplementation at the same time, you should. If they're intubated, put an NG tube in, you should put it through the NG. You're going to be able to get more potassium in quicker. And on top of that, it takes a very long time to actually get your potassium levels up. Just like with magnesium, right? Like you don't always see everything reflected exactly the way that it is. You always learn that 10 milliequivalents raises it by 0.1. Once you rotate it through the ICU, if you repeated stuff overnight a million times, you see that it never works that way. You have to do way more mag potassium to get the levels to where you want. So just remember, practically speaking, that if you really want to do that, you don't just order the IV. You need to try to get them to take some oral supplementation, and if they can't, put an NG2.
Hypokalemic patients are hundreds of milliequivalents.
Yes.
In potassium. You have to remember that most potassium is in your cells, right? So you have to replete that first before you get your serum potassium back. So if you have someone who is 2.5 magnesium, get in 200 or 300 milliequivalents over, a day to get the magnesium up. So you're not going to correct them in the emergency room. But if they have an arrhythmia that you think is from hypokalemia, they need the IVK riders.
Yes.
But they also need the PO because you just can't get enough potassium by the K riders. The K riders may be during this equilibrium period. While it's dripping in, the K will go up a little bit. But you have to fulfill the intracellular space first. And when someone's hypokalemic, you should always assume if they're from diuretics or diarrhea that they're hypomagnesemia too.
Mm-hmm.
Do we have isopropyl? Because I remember on this case we talked about it.
We do. It's on form. But it's almost never used. This is probably the only indication there is.
Question is, do we have isoproterenol? And the answer is yes, we have isoproterenol on both sides of the street.
You could always use epinephrine too. Right? Epinephrine is good data.
A trick I learned from the nurses here is that you can order a D5 normal saline with 40 milliequivalents of potassium in it, and the nurses can run that a little bit faster because it's considered an IV fluid. So if you don't want to use the K riders because the patients might complain of burning or whatever, you can do the 40 milliequivalents in 1 liter bag, and it comes up, and then the nurse can run that.
But that's dangerous because sometimes the bag just runs in really quick.
Yeah,
that's a big dose. That's like a lethal dose.
And then I was going to ask if we were talking a little bit about COVID patients coming in, like a lot of DKA patients coming in with hypokalemia, hypomagnesemia, going into strange arrhythmias. We've had a lot of torsades in our resuscitations. So this is actually a very poignant lecture right now.
Ronnie just said that he noticed that a lot of COVID patients are coming in with diarrhea, having electrolyte abnormalities, going into torsade. He actually asked me this the other day. I kind of looked into it. You're right. The most common reason they're probably going into it is from the diarrhea and the electrolyte abnormality. And then patients on the floor that could be going into it is because of the new drugs that people are using, like the hydroxychloroquine and the azithromycin being used together. Those both are QTC prolonging drugs that can lead to torsade.
I think there's one other thing too that might be contributing at least to the hypokalemia, and right when you're looking at the patients and you're getting your blood gases, right, everyone's alkalotic, and so I think that is driving part of the potassium down a little bit as well, right, from transient. I'm not saying, I don't know what to do with that, right? But I think that's why we're seeing so much hypokalemia in our COVID patients, because they're so tachypnic. They're getting so much respiratory alkalosis that it seems to be, I think that it's driving it down. I don't have any other proof to say that. But there's plenty of patients I've had that don't have diarrhea or anything like that. And they're all alkalotic, and almost all are on the lower end of the spectrum for potassium. So just keep that in mind.
Dr. Hassel just mentioned that most of these patients are respiratory alkalotic, which could be driving the potassium intracellular, leading to the hypokalemia. So they can be hypokalemic even without the diarrhea. So just keep an eye out for that. All right. Thank you.
Okay.